I'm Jonathan Ramachenderan. I'm an FPM board member and pain specialist from WA. I'm really excited because I'm here with Dr. Jelena Janjic. Did I say that properly?
Yes.
Oh, Dr. J. We've just heard you talk, and that was fantastic.
Thank you. Thank you so much.
No problem. And you talked about nanotechnology and its application to chronic persistent pain.
Yes.
I've listened to your TED Talk.
Oh.
And I've
Thank
also
you.
listened to and read some articles about you. So I'm really interested. You shared a lot about your personal story, but I'm interested to know what you go back and tell yourself when you started this journey about what you found out along the way.
Yeah, I have shared today, the technology and also the organizational approach to integrate a lot of disciplines into the Chronic Pain Consortium, and many groups I've been part of, was inspired by, my own experience as a patient, and also trying to understand what was happening to me. In 2010, when I started researching chronic pain, knowing that now I have to live with it, I have got frustrated with what was offered. The medicines were looking at as something that I will have to take for the rest of my life. There was really no good plan of what to do when I was older. So you're looking at a time when I was in my mid-30s, and I remember asking, well, what's going to happen when I'm 60 or older? And because I had training in immunology to some extent and nanotechnology, you start from what you know.
Yeah, of course.
So at the time, the nervous system was really primary focus of research, both the central and the peripheral. And at the time, when I started researching, I came across something called neuroinflammation. And then looking into more deeply, it turns out, the immune cells seems to drive a lot. Can we actually design intervention? And then this whole idea of moving with the body, like you yourself, as you have chronic pain or any other painful condition, you're not the same in the morning and the afternoon. You overdo your exercise the day before. But the medicine that's given is twice a day, 800 milligrams of ibuprofen, for example. Well, that ibuprofen doesn't know that only your knees hurt. So that's where that metaphor came from the TED Talk. You're trying to, flood the whole city just to put out a fire in one house.
Yes.
So can you target the treatment to the actual source of pain? And at the time, in 2011, I was a junior faculty, very enthusiastic, and I had no idea the implications of trying to innovate as we did. But I wasn't alone. I immediately, reached out to others. We formed a group called Chronic Pain Research Consortium at my university, and we started looking at things differently. I partnered with a neuroscientist, Professor Pollock, and we came from two different angles. And then the innovation really came out of that partnership and a lot of other interactions. So I do pinch myself from here. When Buzz reached out, first I was like, why me? But then he said, like you. Yeah, he saw my TED Talk. Actually, I'm very blessed with that TEDx talk at Carnegie Mellon because it was students who reached out.
And asked you to talk.
So I've been kind of fortunate that people learned about the work in different ways, mostly through students. And then also it led to decide how much of my own personal life will go into describing the motivation for all that innovation that to date produced 6 PhD students and many trainees. We published a lot, but I'm more proud of the trainees that we actually brought into immunology and neuroscience, and also the interface of the two disciplines. And a lot of mechanistic understanding came out of this work. So on May 3rd, I'll have a plenary talk that talks about sex difference in pain, that actually we were able to understand more about the immune system sex differences that was not known before. With the technology that we are developing as treatment, becomes a tool to understand the mechanisms. And then if anyone wants to learn how to design nanomedicine, I have a workshop on the 4th, and it says you can design nanomedicine, so maybe you should come.
Yeah, I will too. So would like to know, as pain specialists, in listening to your talk, we're really interested in application.
Yes.
Can you tell us, in our patient population, we were talking before that we see a whole range of different types of people with different types of pain. Can you talk about applications to our patient group?
Yes, of course. So the more immediate application is for treating the patient right after injury or during or right after surgery, trying to address this immediate tissue damage that seems to drive inflammation and neuroinflammation that drives pain. And our proposal has been for the last 15 years that would that intervention prevent chronic pain development. It is known that between different people, the immune system responds differently to the same type of insult. Who is going to develop chronic pain and who doesn't, we don't know. But the idea is that if you can intervene very gently with the immune response to drive it towards pro-healing and pro-analgesic behavior, then you might be able to prevent chronic pain, ideally. Support healing, which we have some evidence that we can do in some of our preclinical studies, and basically use it as a treatment that will be one dose or infrequent dose. Now, if you want to translate this to more chronic inflammatory conditions, we don't have as much data right now, but that's where we're going to go further. Is the idea is that these interventions will be acting more like changing the immune response, let's say in injured knees or something like that. We do find that this mechanistically translates among different contexts, again, preclinical research, and that also gave us an idea that we might be able to tune these interventions depending on the situation that a patient is in. So ideally, with the imaging support that comes with these nanosystems, you'll be able to tailor to your patient, but not only between patients, but within the patient. And that's where my personal experience comes from. The pain is not static. It's temporally varies and spatially varies. And a lot of patients, how you feel at noon and how you feel in the afternoon might be different, but yet your medicine is the same. We are trying to design the medicine that works with the body and modulates. We're not trying to kill off the immune cells. No, we don't want to interfere with their natural ability to, promote healing or promote clearance of infection or promote clearance of debris. You don't want to create this immunosuppressive effect. You want to just gently modulate it so it promotes the pro-healing effects.
And with that, as pain specialists, we're very interested in neuroinflammation. We know that drives many of our pain conditions.
Yes.
You brought up an idea that everyone was very interested in around M1 and M2, around macrophages.
Yes.
And we're trying to go towards more anti-nociception. Can you talk about this M1 and M2 switch as it relates to neuroinflammation?
I can. And again, I have to be very honest, M1, M2 is quite oversimplifying it.
Yes.
But if we accept that, M1s are perceived as pro-inflammatory, but they're also necessary to clear debris, to clear infection. The idea is not to, remove one and keep the other, but actually modulate the transition that naturally happens a few days after injury. And it seems to be, based on our understanding in multiple animal models, is that these shifts vary in the context of type of injury, whether nerve and muscle are both involved or is just nerve involved. Is it, inflammatory insult, like we've done with some of the mouse studies? It seems to matter when things happen. So with our technology, you should be able to chase that shift and tune it in the right time. So you don't want to remove the M1s completely because you will basically interfere with normal healing, but you also don't want to let them stay on too long, which is one of many mechanisms that might be driving the longer lasting pain. And this shift to M2 in certain contexts in our data seems to suggest that we are able to promote healing, to accelerate it. And we're now designing studies to look at wound healing specifically. Right now, it's more anecdotal, what we've seen in our other surgical models, but we've seen, wound closure being better. Also, some signs of neuroregenerations were observed. So we think we can capitulate on that. But again, the whole idea is whether it's M1 or M2 or any kind of in-between phenotypes, you want to look at it more holistically and modulate these shifts and changes. Now, don't forget, once you intervene with that one immune cells, the other cells are not sitting there waiting. They actually respond to that change. And we've published this in 2019. Mast cells, for example, responded. Then there is more research going on to look at T cells and dendritic cells and other immune cells. So what we have seen is that basically once you intervene early, whether drug persists in the tissue or not is no longer relevant as much because you have caused the change. And that's where the nanoparticles come to become very important, because once the nanoparticle is taken up by the immune cell, the immune cell starts changing. That immune cell retains the nanoparticle for a while. It talks to its neighbors. So you have this targeted cells, but also off-target cell response. And studying that is very complex. As I said, we've got 6 PhDs, and we have a couple more students that are going down this path to understand the sex differences, to understand the downstream effects, and also what happens upstream to set this up to be actually accessible for our intervention. We don't know yet all the answers, but we are moving into that direction to understand neuroinflammation by intervention that's meant to be therapeutic, but it's also working as a tool as well.
Good. And so, Jelena, you're giving a talk, and you're also going to be running a workshop.
Yes.
The talk is on gender differences or sex differences.
Yes.
And you're also running a workshop which you're really passionate about. So if people are very interested, there are places left, and you were telling me that you're going to take people through, is it design to application? Yes,
the workshop is meant to give a bit of a flavor of one of the courses that I teach in my graduate program. It's called Drug Delivery Systems and Bioengineering. I'm trying to teach people to design how to move technology towards what patient really needs, rather than design something that will be cool and attractive, but doesn't really do the job. So taking all of these ideas and trying to come up with a conceptual design. And I will tell you from my experience teaching like this for more than a decade, that you really don't need to be an engineer to start thinking like one. And that's the focus of my actual workshop, is trying to bring clinicians and like yourself and others to start thinking how to design technology, because that will move this technology in the future faster to actually improve patient care.
Excellent. Thank you for spending time with us.
Thank you for having me. I appreciate it.
No problem.